Firstly, I would like to welcome our first speaker, Heenal Narsey, who will be presenting on severe and very severe myalgic encephalomyelitis in Australia, focusing on the role of speech pathologists in this neglected patient cohort. Thank you.
Thank you, Sam. And firstly, I just wanted to thank ME Group Australia and Rachel for providing me with such a valuable opportunity today to share my insights into the role of speech pathology and our important role in caring and supporting people with severe and very severe ME. So I'm just going to firstly share my slides. Okay. So today I'll be drawing on the emerging international literature, Australian health system gaps, and my own clinical experiences supporting people with ME. I'll also highlight why this group needs urgent recognition, what makes their presentations unique, and how speech pathologists can play a vital role in improving the quality of life with people with ME. So I firstly wanted to go over why severe and very severe ME matters. So they represent the most profoundly disabled group within the ME spectrum. So these individuals are often housebound or bedbound, and many rely on full-time care. And despite this, though, they remain under-recognised in health policy and service delivery. So this means that individuals are left without adequate management options, without equitable access to rehab services. And so addressing their needs is essential to ensure equity and access to care, appropriate clinical management, and capacity building for support workers. Firstly, I wanted to go over what is severe and very severe ME. So they are the most debilitating forms of ME, where people experience profound physical and cognitive impairments that drastically limit daily functioning. So severe ME means that people are mostly housebound. They may rely on mobility aids and struggle with even the most basic activities like eating or self-care. Very severe ME is even more devastating. So individuals may be completely bedbound, highly sensitive to light, sound, and touch, and sometimes reliant on tube feeding for nutritional intake. And I really wanted to highlight today that both of these groups experience post-exertional neuroimmune exhaustion. I'm so sorry, excuse me. So this again means that even minimal activity can lead to significant worsening of symptoms. So I wanted to highlight again that this means that people with severe and very severe ME live with constant pain, exhaustion, and sensory overload, making them among the most medically neglected and socially isolated groups. So clinically, we often see overlaps between ME and other neurological conditions, such as Parkinson's disease, multiple sclerosis, or traumatic brain injury. So some similar presentations, we look at language difficulties. These include word finding challenges and reduced verbal fluency. We might have cognitive challenges, which include slow information processing, short-term memory difficulties, and also attention deficits, which are also quite common. Voice changes are frequently observed across these presentations. So we can present with dysphonia. So that's where an individual might have strained, breathy, or hoarse voice. Or they may also present with aphonia, which is a complete loss of voice. And then similarly with difficulties, this can present as slurred or imprecise articulation, which is often reflective of dysarthria. And then we also can see features across these presentations presenting as dysphagia, so swallowing difficulties. So these conditions can present as difficulties chewing, swallowing, weakness to swallow muscles, and difficulties managing saliva. So it's also really important to note that while ME can present quite similarly to other neurological conditions, they do have unique features that set them apart. So the most distinctive is post-exertional neuroimmune exhaustion, so PENE. So unlike MS or Parkinson's disease, exertion doesn't just cause fatigue. So for those with ME, it triggers a disproportionate prolonged crash. So even minimal physical, cognitive, or sensory exertion can cause a prolonged worsening of symptoms, and these can last days, weeks, or even longer. People with ME also experience neuroexhaustion, so with minimum exertion, meaning that basic activities such as speaking, sitting upright, or eating may be intolerable. They also uniquely present with orthostatic intolerance. So this is another frequent and debilitating feature where symptoms often worsen significantly upon sitting or standing upright. So this further restricts independence and mobility. Alongside this, there are extreme sensory sensitivities to light, sound, touch that I mentioned earlier, and this can make standard clinical approaches unsafe or intolerable. And so these unique features, therefore, really demand highly tailored, cautious, and really compassionate clinical assessment and management for people with severe ME and very severe ME. So let's quickly look at a case example. So this client presented with significant communication and swallowing challenges that was associated with a very severe ME diagnosis. So their language difficulties were characterized by increased word finding challenges, and this resulted in them presenting with disruption with their communication flow. Cognitively, they demonstrated reduced short-term memory, slowed information processing as well. Their voice function was notably affected by ongoing neurological exhaustion. So this led to them presenting with persistent dysphonia, so that very soft voice presentation. And they also can experience that intermittent aphonia, so that complete loss of voice. Consequently, this person with severe ME, very severe ME, expressed interest in assistive technologies, including voice amplification devices and speech-to-text applications that had pre-programmed phrases as a form of communicating. Their speech was also further impacted by slurring, and this particularly occurred during episodes of neurological exhaustion. And lastly, they also presented with dysphagia, and this included difficulties with chewing, swallowing of foods and fluids, and clearance of saliva due to neurological exhaustion. So in terms of therapy recommendations, for language, we would focus on strategies to support word finding difficulties and also ways to promote conversation flow. For cognition, we would provide supports with memory aids, strategies to reduce cognitive load. Voice recommendations would include conservation strategies, amplification devices, and speech-to-text apps, like I mentioned earlier. And this would have a real focus on that functional communication. We also ensure that support workers are provided with capacity building to facilitate our therapy recommendations. And in fact, this is quite vital to include as part of the intervention. Other recommendations include for speech clarity, we'd introduce strategies to maximize intelligibility during periods of neuroexhaustion. For swallowing, a personalized mealtime management plan is critical. This includes texture modifications. It would include information on pacing, positioning as able, and environmental adaptations during mealtimes. I wanted to note here that support worker training and again capacity building is really essential to ensure safety and consistency throughout recommendations, particularly for dysphagia management. For example, when presenting texture modifications, we need to ensure that the client has the appropriate texture modification or fluid thickening. And then we finally focus on generalization, so embedding all those strategies into daily life activities so they're not confined to just the therapy sessions. And this is where it's really important that we see if we need to refine any further recommendations, and if we need to update any support worker capacity building to ensure that we can all facilitate effective rehab. So in light of the therapy recommendations, we must consider the clinical challenges for people with severe and very severe ME. So as we've noted earlier, PENE means that even minimal exertion can trigger significant and prolonged deterioration. So this can make traditional therapy approaches unsafe or intolerable. The neuroexhaustion also further limits abilities to tolerate sustained interaction. And if you think about sustained interaction, this is a big requirement for a standard therapy session, for example. And then I wanted to also highlight that people with ME cannot generate energy on demand, and that cellular transport issues means that rest does not restore function. And then we have the consideration of the orthostatic intolerance, which further adds complexity where symptoms worsen when sitting or standing. So this, again, can restrict potential assessments, therapy settings, and then also positioning during those sessions. So already we can see that these factors really demand that highly individualized, low stimulation, energy conserving approaches, with speech pathologists having to prioritize pacing, minimizing triggers, and really adapting that flexible, compassionate method of communication and intervention to essentially avoid harm for the individual with ME. So I thought we'd put a bit of this into practice and what that kind of looks like when we do have a client, an individual with severe or very severe ME, and what we can do to troubleshoot as a speech pathologist. So I've got a few examples here today. So say for a task that includes a 5-minute picture naming activity, this could potentially trigger the individual with ME with days of severe exhaustion for a person that may be having those symptoms in that day. So then we would consider keeping assessments very brief, allowing extended recovery time, and having breaks, breaking up therapy rather into micro sessions if tolerated. So that would be an example reflective back to PENE. And then we've got an example reflective of neuroexhaustion. So say after only 2 or 3 questions that the clinician has asked the client, they may experience slurred speech or cognitive shutdown. So what we'd consider here is to use yes or no or alternative communication supports, and we'd stop sessions as soon as signs of decline appear. The third example here is reflective of the client with ME if they have that inability to produce energy on demand. So if I was to present them with swallowing trials or go through clear speech drills, this often can't be repeated within minutes for people with ME because, as we know, energy doesn't restore that way. So we need to consider how we can avoid repetitive drills or exercise-based therapy, instead really focusing on energy-preserving strategies and compensatory supports, which, again, we still need evidence for. So this is why it's so important to have evidence-based research for speech pathology within the ME space, because there's just very little guidelines for this. So the last example I've got here is for the orthostatic intolerance. So what might happen is therapy can only be possible reclined or at a bedside position. So something to consider here is to adapt postures, conduct therapy at bedside, allow lying positions, and then also utilising telehealth as well during this time. I've also mentioned having support workers to mediate strategies if the upright tolerance is limited for a short amount of time. So we can try to, use that as an advantage where able to at least incorporate a bit of the therapy in that upright position if possible. I now wanted to quickly highlight the research gaps in speech pathology and ME. There is minimal research available at the moment, and we have very little evidence on how best to support communication, swallowing, and cognitive communication in this group. There is particularly concerning. This is particularly concerning for severe and very severe ME because conventional therapy approaches may actually be unsafe due to the PENE and related features. So as clinicians, we are currently left with, really limited guidance, and this places both patients and therapists in difficult positions. So because of these significant research gaps, there's an urgent need for targeted speech pathology research in severe and very severe ME. This is really important for us. So in doing this, we can investigate safe, effective, and adaptive interventions for this population, including the role of assistive technology, support worker training, and dysphagia management in energy-constrained contexts. So this is where it's really important because like we've mentioned previously, how ME can be presented similarly with other neurological conditions. Where ME does differ again is that we have to make sure that assessment and therapy and management is presented in a way that's energy constrained in that context. So again, we really need that research and guidelines for this neglected patient cohort. The NHMRC Clinical Guidelines Project again gives us an opportunity to embed ME-specific recommendations. So this would ensure that people receive evidence-informed, equitable care, and that clinicians finally have guidance on how to adapt interventions to ME's unique pathophysiology. So again, urgent research and guideline inclusions are really essential to improve the outcomes for those in this population group. So I wanted to conclude by highlighting that communication is a fundamental human right. People with severe and very severe ME face profound barriers. They may be too unwell to attend clinics or too neurologically exhausted to undergo standard assessment. So this leaves their communication needs quite invisible and unmet. So they are profoundly isolated and often cannot advocate for themselves. So this is where my role and every other speech pathologist's role is plays a lot of importance. So we therefore play a dual role, not only as clinicians, but also as advocates. We must push for equity and service delivery, ensure the inclusion of ME within clinical guidelines and health policy to ensure that no individual with ME is left without a voice. And then to summarize here, I wanted to again highlight that ME profoundly impacts communication, cognition, voice, and swallowing. In severe and very severe ME cases, individuals may be unable to speak, eat safely, or participate in daily life. Speech pathologists can support autonomy, safety, and quality of life through tailored communication supports, assistive technology, and dysphagia management. But at present, unfortunately, there are major gaps. So there's no condition-specific guidelines and there's minimal research. And there is a lack of that specialist training due to lack of studies with efficient and sufficient management. So where do we go from here? So I've just included a little slide about what we could do moving forward together. So we must really support inclusion of speech pathology within the NHMRC guidelines, advocate for equitable service delivery so that no one with ME is excluded, push for that targeted research into communication, voice, swallowing, and cognition. we must, raise awareness for ME's unique challenges across the health systems. And then most importantly, work together to uphold the rights of people with ME, and ensuring that they are seen, they're heard, and that they're supported. And that was it for me today. Thank you so much for your time and for listening to, I think, a really important space, I think, for the role of speech pathology in people with ME. Thank you.
I wanted to open the floor to see if there were any questions for Heenal.
Sure. Thank you.
I'm happy to start. So I noticed during your presentation, you presented very well the role of the speech pathologist, and there's multiple domains that speech pathology covers, and it's very integral to helping with people with ME.
Sure.
I guess there's also quite significant research gaps because a lot of the traditional approaches may worsen the symptoms of people with ME. So I was wondering, for example, in the hospital, we would encourage people to sit up, chew food thoroughly, and so forth to minimize aspiration risk. But like you mentioned, it may worsen things like postural orthostatic symptoms. Things are still developing in the research space. Are there any early recommendations from speech pathology in terms of how clinicians or carers can support people with ME to get better nutritional intake with their swallow safety?
Definitely. And that's such a great question. And again, I guess the research is still happening, but from my own clinical experience, we do recommend if the individual is able to lay at a 40-degree angle. So we call that a semi-Fowler position, where we're almost laying down, but we're slightly raised for a short amount of time. If the client can do that, we can then present them with the appropriate food and fluid. In terms of accommodating for the chewing, we would then use some modifications, Stan, on how we can minimize chewing. So in the past, I have modified the food, so I've cut it up, not to mean to modify the food to puree, but rather chopping it up into bite-sized pieces, presenting softer foods to then assist with the mastication process. So that in the past has helped, but then also making sure we're checking in every time that, is the patient okay to continue that oral trial? Because the worst thing to happen then is they start getting neurologically exhausted mid-chewing, and then we can have that risk of that choking. So that frequent check-in is important as well.
Great, thank you. Were there any other questions at the moment?
I have a question. So it's Penelope. Heenal, I'm on the guidelines committee.
Yes.
And I'm really interested, not just for speech therapy, in this idea of adapting therapies into micro sessions. It's not how it's not how our health system is set up. And it's certainly not common practice. And yet it's not just speech therapy where for people who are more severe, if they're well enough to receive any therapy at all, the idea of microtherapy just as a concept seems really, really important to me. And I don't think I've seen it in other guidelines, and I'd love to see it in ours.
Yes.
So I'm wondering if you can sort of, are there resources for that?
Yeah, and this is again, Penelope, quite a new space for myself, which is what's inspired me to research so much into ME, in particular severe and very severe ME. And I think this is a learning process for me as I start my journey, even as an early grad speeching myself, to find ways in seeking those resources. As of now, I haven't been able to find what that really does look like, in all honesty, Penelope, but I will, I guess, continue to also trial and error myself clinically to see what works best for my client and future clients with ME.
I just think that it's a really broad topic, right? Because it can apply to any sort of allied health practitioner.
Yeah.
And it can also apply to nursing interventions and ideally apply to interactions with doctors of every description. And whether it's in the home or whether the person happens to be in hospital or residential care,
Yeah,
the same policy applies, but it's just not how our system is set up. So it's quite an interesting notion of actually building that into the guidelines, saying, "Oi, you lot."
yeah, yeah. I've just seen something that Sarah put in the message in the chat, which is so true. She's mentioned that she would love to accommodate micro sessions, but can imagine it being challenging with different funding models. And that's such a
Exactly.
valid, yeah. And that's again something in the space for speech pathology that we can advocate for. We give the rationale as to why this would be beneficial for the client with ME. And again, I think that will be a great starting point to see if this can be accommodated. So I think a lot of advocacy is important here to
Yes.
really facilitate that.
Do you have another question from Rachel in the chat? If you could briefly describe what the speech therapy for ME may look like.
Yeah, sure, Rachel. So I guess it'll differ depending on the client and what difficulties they may have. But let's say they may have difficulties with the communication. So we would then really trial some augmentative and alternative communication supports to see if we can supplement communication through low tech or high tech assistive devices. We look at training support workers in communication partner techniques. So, waiting time, checking yes and no, avoiding that overload. So I spoke a lot about energy conservation. So really working on that communication partner training, voice conservation strategies as well to help reduce strain if dysphonia is present. And so again, what that might look like is definitely not something that will be prolonged and provide that overload, but in short little bursts. So instead of having a drill of exercises, this might be really minimized to a few that the client can tolerate, for example. Then, of course, if there is swallowing or meal type management needs, then we'd look at positioning recommendations, texture modification that's aligned with the IDSI standards, really focusing on support worker training with feeding practices, pacing, monitoring for fatigue, and again, that energy conservation. So presenting those smaller, more frequent meals, possibly adaptive utensils that can provide them with independence at meal times, because we always, like as speech pathologists, want to maintain independence at mealtime. So adaptive utensils have also been something to consider as part of the intervention. So in a little snapshot, it can vary depending on the individual, but those are some of the general kind of things we'd work on in therapy. I hope that helps.
I've got one question here.
Yeah.
Sorry. You briefly mentioned telehealth. I'm just wondering if most of the ME patients or population that are homebounded, I'm assuming that the most conventional way of accessing healthcare is through telehealth or telemedicine. So I'm just wondering how easy it is for them to have that access, or do they have experience and difficulty accessing telehealth, or what does it look like for the caregivers of ME?
Yes.
If they want any consultation or anything regarding the patient?
Yeah, so great question. Excuse me. I can only unfortunately talk back on my previous experience with clients with other neurological conditions. I haven't yet actually engaged in telehealth with people with ME. However, in saying this, just from experience with facilitating telehealth, a device, the setting up process, it has been quite seamless. There hasn't been any issues, especially if I go there in person to assist and then facilitate that capacity building for the support worker, making sure that they're able to do it on their own whilst I'm still there. And then future sessions being via telehealth, I haven't had many difficulties facilitating a telehealth session.
We've got time for one more question. Would anyone like to?
Robin's got one. My speech is affected by ME resulting in staccato speech. What is treatment for staccato speech? Right. So, staccato speech, firstly, presents as short, effortful bursts of speech. And this can often reflect by reduced breath support, in coordination of the speech muscles, so in our throat, and then obviously the neurological exhaustion. In terms of treatment, focus would be quite different than, let's say, classical dysarthria or other voice management because of the ME-specific energy limitations. But the first thing in terms of treatment is we'd obviously have to assess first. So we'd check the underlying mechanism. Is it respiratory? Is it neuromotor? Is it fatigue, exhaustion related? And then in terms of treatment, so again, with that, treatment will depend on what kind of mechanism is affected, if that makes sense. And then we then go on the treatment principles. So we think about whether therapy can be compensatory or can it be conservative. So we try and work that out with the individual. But some things that we can work on is breath speed coordination. So remembering that staccato speech is characterized by that short clipped bursts of speech, which can be quite effortful. We really work on that breathing, so that gentle breathing, pacing exercise, cueing ourselves to speak in smaller phrases, matching to our available breath. So we're really focusing on breathing as I think our first point of call. We then look at rate and rhythm strategies. So I've in the past used slow rate pacing boards. So we use boards to really tap, per syllable of the word or per syllable per word. And we use a lot of visual supports to really facilitate pacing, and then chunking sentences into those smaller parts. Just trying to think on the top of my head. We might even look at contrastive stress drills. So we work on prosody and intonation of our speech and our voice. So instead of, we say, I want tea instead of I want tea. So really working on that prosody as well. But from memory, I can definitely say that breath speech coordination is a big one, and Sarah, you might be able to help me with this too. And then of course energy conservation and communication supports again are essential, especially when it comes to voice. But just to recap, breath speech is a big one where we use that breath pacing exercise, especially for staccato speech.
Thank you so much for presenting, Heenal, and for answering all of those questions.